Hi, everyone. Thank you for joining us today for our webinar, FHO Plus, Preparing Your Practice for What's Next. We'll give it just a couple moments as people continue to join. All right, let's get started. For those who haven't seen me before, my name is Daniel Brenner, and I'm the Senior Director of Operations here at Doctor Care. We're also very pleased to have Dr. Adam Stewart, an Ontario family physician and recognized expert in practice efficiency, digital health, and the evolving economics of primary care. Dr. Stewart will share his perspective from a frontline practice on the upcoming FO Plus changes. Just to note, he's joining us as an independent expert, not as a Doctor Care customer, and that he is not appearing or speaking on behalf of the OMA or SGFP. Dr. Stewart, welcome. It's great to have you with us. I'll pass it over to you to introduce yourself.
Oh, thank you, and thank you for having me. I don't think I've ever spoken to a group this large before. For those who don't know me, I'm a rural family doctor coming up to about 17 years in practice. And like I said, I have many roles and wear many hats, but today I'm just here as my own personal Dr. Adam Stewart, not expressing the views of any other entity. But again, pleasure to be here.
Thanks, Dr. Stewart. We're excited to have you. So today we'll be walking through several key updates to the FO Plus model and what they mean for your practice, including the hourly time-based payment and billing structure, shadow billing requirements, procedure code and premium increases, patient attachment bonuses and new codes, continuity of care and the 75% threshold, and finally, practical optimization strategies to help protect and grow your revenue. Please note that this information we're sharing today reflects the most current updates available from the OMA and may change as implementation progresses. Before we dive in, many of you are already familiar with Doctor Care. But for those of you who are not, we are the largest provider of medical billing and practice management support to more than 4,000 physicians across Canada. On average, we help physicians recover between $25,000 and $30,000 in revenue annually. We also support approximately 25% of all family health organizations or FOs in Ontario. Our solutions are designed to help physicians optimize operations, strengthen revenue performance, and ultimately enhance the quality of care delivered to patients. Just for some quick webinar logistics, all attendees are in listen-only mode today. We are recording this webinar, so it will be available to you after the event. We'll aim to keep this session to approximately 1 hour. If you have any questions during the webinar, please submit them in the Q&A feature, and our team will do their best to answer them during the session. If we are unable to answer your questions, one of our team members will follow up with you after the webinar. I do want to reiterate to not wait to the end of the webinar to ask your questions. We usually get a bunch coming in, in the last couple minutes. We have a lot of content to get through today, and we want to make sure we can answer as many questions as possible through the Q&A feature. Let's begin with a high-level overview of the FO Plus model and how it compares to the previous FO model. At a broad level, FO Plus adjusts how compensation, incentives, and accountability are structured within the model. First, hourly time-based payments recognize the full scope of physician work, including clinical care and administrative responsibilities. With patient attachment, physicians will receive compensation for rostering unattached patients, along with enhanced incentives tied to specific patient situations, such as rostering a mother with a newborn and increases related to Healthcare Connect codes. These changes support both access and patient complexity. We'll also see increased shadow billing from 19.4 to 30%, increasing the amount physicians will receive from in-basket codes for rostered patients. Financial updates also include increases to certain procedure codes up to 50%, an increase in the Q012 after-hour premium code, and a new enhanced group management leadership payment or GMLP. Operationally, inpatient hospital services will move from in-basket to paid at 100% for rostered patients seen during admission, affecting how hospital-based services are counted and compensated. There will also be an updated FHO regulations along with phase out of the access bonus, which will transition into a continuity of care framework tied to the 75% threshold. Taken together, these changes reshape how performance and compensation align under FHO Plus, making proactive planning critical. Now, on to how you will earn under the FHO Plus. We'll dive into what physicians are asking the most. The new hourly rate of $80 will compensate physicians for time spent providing direct and indirect patient care, as well as doing clinical administrative work. The hourly rate applies to all insured services for your FHO rostered patients, including both in-basket and out-of-basket codes. The ministry and the OMA have also confirmed that care provided to roster patients in long-term care will be eligible for the hourly rate. Now, let's walk through how the hourly rates are structured under FHO Plus. For direct patient care, the standard rate is $80 per hour. This applies to care delivered either in person or virtually. The exception to this is if you are providing telephone care while you're out of the office. The rate is $68 per hour, which represents 85% of the standard $80 rate. For indirect patient care, the rate is also $80 per hour. This includes the work that supports patient care outside of direct encounter, activities that are clinically necessary but not face-to-face. Similarly, clinical administration is also compensated at $80 per hour. This recognizes the operational and oversight responsibilities that are essential to running your practice effectively. It's also important to clarify that all services billed under the hourly rate, whether direct care, indirect care, or clinical administration, are considered medically necessary. Therefore, they are exempt from the HST. If you are currently working in a FHO, you will automatically be practicing under FHO Plus with an hourly rate starting April 1st, 2026, a week away. Now, let's review how the hourly rate is calculated and the billing limits that apply. Time is billed in 15-minute units, calculated cumulatively across the day. If the remaining time at the end of the day is 8 minutes or more, it will be rounded up to the next full 15-minute increment. There are also maximum thresholds to be aware of. You can bill up to 14 hours in a single day and up to 240 hours over 28 consecutive calendar days. This averages out to approximately 8.5 hours per day. There are also proportional limits across care categories. Over a 28-day period, up to 25% of your total billable hours can be allocated to indirect care and clinical administration combined. And within that, clinical administration alone is capped at 5% of your total direct and indirect care hours. So practically speaking, this means that for approximately every 3 hours of direct patient care, you can bill 1 hour of indirect care and clinical administration combined. In other words, up to 33% of your direct patient care hours can support billing for indirect care and clinical administration. Understanding these ratios is critical to ensuring you are not billing over the maximum while fully capturing eligible time under the model. Dr. Stewart, anything you'd like to add regarding the billing limits and caps?
Yeah, I just wanted to emphasize and highlight exactly what you just said, and that's that I think the main point here is to know that this 25% cap is unfortunate because all of the evidence suggests that us, and anecdotally, all of us family doctors know we're doing about 1 hour of indirect care for every 1 hour of direct care. So, I mean, that's fine. If people don't want to change anything, they can carry forward as such. But if you want to optimize the model, there's going to be probably some adjustments needed in scheduling patients more direct time phone calls, direct visits in order to grow that direct direct care pie in order to therefore be able to grow the indirect pie amount that you can bill to under the 25% cap.
Yeah, definitely. And I think we get into more of that later on as well. Thanks, Dr. Stewart. Let's talk about how these services will actually be billed for. There are unique fee codes for each category of care eligible under the hourly rate. For direct patient care, the Q310 is a dedicated fee code that applies to all eligible direct care, including time spent personally delivering insured clinical services to rostered patients, both in-person and virtual visits, as well as clinical teaching that occurs concurrently with patient care. In other words, if you're actively providing insured care to your rostered patients, whether in the exam room or virtually, that will fall under the direct care fee code. There's also a separate fee code for telephone care provided while you're out of the office, the Q311. As we discussed earlier, that category is treated differently from a compensation standpoint, which is why it has its own distinct code. For indirect care, the Q312 is the billable code. These will be patient-specific tasks that do not involve direct patient contact. So things included here are completing paperwork, including charting and documentation, preparing referrals and requisitions, coordinating and planning care, such as chart reviews, reviewing labs, images, consult notes, and much, much more. The rate for indirect care remains the same whether the work is performed in or out of office. It is also important to note that uninsured services will not be included in these hourly rates. Lastly, for clinical administration, the Q313, this will be for time spent on non-patient specific but clinically necessary activities. This includes work like proactive patient management initiatives, which include screening programs, chronic disease management planning. It's also for EMR updates that require physician expertise, as well as participation in quality improvement initiatives. These are activities that support patient care at system levels, even when they are not tied to an individual patient encounter. It's important to clarify what is not included in this category. Clinical administration does not cover non-clinical operational tasks, things like human resources, finance, supply ordering, or general clinic management. It does not, it also does not include time spent documenting your own hours. As with indirect care, the rate for clinical administration remains the same whether the work is completed in or out of office. Together, direct care, indirect care, and clinical administration creates a more comprehensive framework for recognizing the full scope of physician work under the hourly model. It's important to understand that the hourly rate applies specifically to services delivered within the core family practice setting. Services provided outside of the setting are not eligible for the hourly payment. This includes care delivered in emergency departments, in-hospital services like specialist work or obstetrics, anesthesia services, surgical assists, and independent health facility work. Additionally, services provided to non-rostered or uninsured patients, which includes uninsured services, are not eligible under the hourly rate structure. For further context, let's take a look at an example of how your time is calculated in a week. You'll see under the work category, Dr. Johnson has a breakdown of 46 hours of direct in-person care worked, 8 hours of direct virtual care, 24 hours of indirect care, and 19 hours of clinical administration. This equates to a total of 97 hours worked per week. If you look under the billable category with respect to the billing limits, it shows you how many of those hours are billable for that week. With this breakdown, 72 of the 97 total hours are billable. This alludes to what Dr. Stewart was mentioning before. Again, if indirect exceeds this 25% of the total billable hours, anything above is not payable. As we mentioned previously, the maximum billable hours for each hourly billing category are for a 28-day period. This means that if you go over in one category in one week, you can compensate by working fewer hours in this category another week in the same 28-day period. In addition to the hourly rate for your work, you are paid shadow billing, capitation, and other bonuses. So the hourly rate alone does not reflect your total compensation for work provided. The OMA provides a calculator on their website where you can calculate your total hours for each category and get the total amount of billable hours. Dr. Stewart, anything you want to add on here?
Yeah, it's like we've been saying, if you're an optimizer like me, you're going to want to ride as close to that 25% cap as possible. Most people are easily going to go over that 25% cap, but you definitely don't want to be below it and leaving money on the table, so to speak. But you also don't want to be exceeding it so far, like maybe in this example where you've worked 20 hours for free. So again, working with adjusting how you're scheduling patients and stuff might be helpful if you want to optimize.
Yeah, definitely, definitely. I think we'll be diving into some examples later where you can talk about that optimization strategy too, which I'm excited to go through. So let's review the documentation requirements under the hourly model. You are required to maintain records of your total time spent in each category per day. For direct patient care, it's important to document care provided in office separately from telephone care provided while you're out of the office, as these fall under different fee codes. Only the total daily duration needs to be recorded. You are not required to document specific start and stop times. Documentation also does not need to be maintained at the individual patient level. For indirect care and clinical administration, you must include a brief daily description of the activities performed within each category. So, an example here might be April 1st, indirect patient care, 1 hour chart reviews, and that would suffice. Best practice when submitting the codes is to create a test patient in your EMR. The patient must be without a date of birth or health card number. On this test patient, you can attach all documentation summaries and submit the billable codes. As with other insured services, the ministry may request copies of your records at any time. Maintaining clear, consistent documentation will be essential to ensuring compliance and supporting your billed hours. For home visits to your rostered patients, you may bill the hourly rate for the time spent providing care to the patient, as well as any associated documentation or charting related to that visit. However, travel time is not eligible for billing under the hourly rate. If you get a locum to cover your FHO practice, the locum is eligible to bill and receive payment under the hourly model when providing services to the FHO's enrolled patients. The key requirement is that the locum must be properly registered through the appropriate FHO channels. Ensuring this is completed in advance is important to avoiding billing issues or payment delays. If you're planning locum coverage, confirming registration eligibility ahead of time will ensure a smooth transition and avoid delays. Now, we recognize that this is a significant amount of information, and for many of you, it may feel like a lot to track and manage. That's exactly why we're proactively optimizing our reporting services to help bridge the gap created by these changes. It is important to note that how our reports will look and what information will be included is still to be determined, but we have provided mock-ups of what these could look like, which are subject to change based off the reporting available from the ministry. As part of these enhancements, your reports may include a dedicated section specifically focused on hourly time-based billing. This section would break down your billed codes across direct patient care, indirect patient care, and clinical administration. It may also include a quarterly overview that summarizes your monthly total hours in each category, along with the corresponding amounts billed per month. This would provide clear visibility into trends, utilization patterns, and overall revenue performance under the new model. Additionally, the report may include an hours utilized section that outlines amount of eligible hours you have used, what your cap is, and how many hours remain before you reach that cap. Similarly to how Dr. Stewart was saying before, making sure you are optimizing for those indirect clinical administrative hours. The goal really is to provide transparency, reduce administrative burden, and ensure you're positioned to capture all eligible revenue while staying within guidelines. Now, let's walk through what's being enhanced under the FO Plus model. We have covered this in depth in our previous FO Plus webinar, which is available on our website. But for those of you who missed it, we'll take you through the additional FO Plus updates. A significant area of change relates to in-basket services, which represents a substantial portion of FO physician billing. Shadow billing, the percentage paid for in-basket services provided to rostered patients, will increase from 19.4 to 30%. This increase applies to all in-basket services, including special visit premiums. It's also important to note that the fee-for-service hard cap will continue to be measured at the group level, not the individual physician level. Monitoring group activity will remain critical, and our team works closely with practices to ensure thresholds are managed and appropriately. With shadow billing increasing to 30%, billing accuracy will become even more important. Even small billing errors can now have a greater financial impact on your practice. Ensuring your claims are submitted correctly and that rejected or incorrect claims are identified and corrected promptly will help you capture the full compensation available under the new model. This is also an area where Doctor Care supports physicians through our billing care service by monitoring remittance reports, identifying billing errors, and resubmitting eligible claims to help ensure revenue is fully captured. Dr. Stewart, I know this has been a popular topic with physicians, so feel free to add anything.
Yeah, I just wanted to drill into this important point because um, some people don't are questioning like, well, how could it going from 19% to 30% really change incentives that much? But it's important to look at a few things. One is 19% to 30% is actually about a 50% increase in that area. But also the actual fee codes have now got permanent raises. Like the A007 is now 44, 45 or something like that. So the actual that compounds between the increased shadow billing plus the actual value of the fee code. And then when you take away and you compound that with the lack of flat rate stability with the access bonus and CCM fees, you've got this pretty big shift going upwards in that rewards volume and time or volume and visits, and then a downshift in the stability of flat rate payments. And that amounts to a pretty significant shift in incentivizing how people might want to practice.
Yeah, definitely changes practice and also makes it more critical to make sure you're billing appropriate codes, getting compensated for all those codes. That's a great point. So in addition, select and office procedures will see fee increases up to 50%. This list is extensive and includes services commonly performed in primary care, such as cervical screening and pap smear, the G365, IUD insertions, the G378, immunizations like G841 through G848, and Z prefix in-office skin biopsies, which include the Z101, Z116, Z117, and others. These adjustments can have a cumulative impact on practice revenue, particularly for high volume services. The full list is available through the OMA website. The increase will not take effect immediately on April 1, but once implemented, the difference will be paid out retroactively and reflected on your RA. After hours care is also seeing improvement. The Q012 after hour premium code for rostered patients will increase from 30% to 50% of eligible services billed after hours. This is a significant enhancement and moves capitation more in line with the time and moves compensation more in line with the time and commitment required for after hours coverage. We often see doctors missing the Q012 billing code, and with the fee increase, ensuring it is captured accurately will be even more important under this model. Another major improvement involves hospital services. Services that were previously treated as in-basket will now move to be paid at the full 100% fee-for-service rate. This ensures more appropriate compensation for hospital-based care. Importantly, Hospital services will no longer contribute to your group's fee-for-service hard cap. This removes a long-standing concern around inpatient services and their downstream effect on compensation. Dr. Stewart, anything to add?
Yeah, the I just wanted to comment on the procedures premium going up to 50%, and that under the original full model, it actually costs faux doctors to do procedures. The material costs weren't properly. It was just as easy to outsource it than do it in-house, and there was no incentive to do it. Now I've done some preliminary math under the good news is under the full plus, it's about neutral, I figure. So it's you could go either way on it. However, uh, the benefit of doing the procedures more in-house now is that it's direct care time. So you're able to grow that direct care a little bit better and thus also grow the indirect pie. And then there's also the category that for those practices who are hovering around the yearly bonus of the in-office procedures, anyone who's below that threshold on a yearly basis now will definitely want to consider bringing those procedures in-house to capture that bonus.
Yeah, great flag. Thank you. Now, let's speak about the upcoming changes to the Group Management Leadership Payment, or GMLP. Currently, FHO groups are eligible for a payment of $1 per enrolled patient per year, up to a maximum of $25,000 annually, which is intended to support the administrative costs of running a team-based practice. Under FHO Plus, an additional enhanced GMLP builds on this existing structure. The enhanced payment provides $4 per enrolled patient, up to a maximum of $100,000 per year per group. This enhancement is intended to recognize the additional leadership responsibilities involved in ensuring compliance with the FHO agreement, including oversight of after-hours availability, contractual requirements, and overall model adherence. Combined, this brings the potential total to $125,000 per group annually. Importantly, there is also a negotiated combined minimum payment of $25,000, ensuring a baseline level of support for group leadership. Enhanced GMLP payments will be paid out at each fiscal year end, but for the first year, the enhanced GMLP will be paid out quarterly and it will be manual until an automated solution is implemented. Dr. Stewart, maybe you can give some insight into how your group is considering using these additional funds?
I think the key thing is that no one's being prescriptive on how to divide this up or just this payment. It's good because usually leadership roles have been an opportunity cost, so it's finally good to have an opportunity to properly reward or incentivize leadership. So some groups might decide that the lead physician is doing all the work and appropriately give all the funds to the lead physician. Our group is in the midst of talking about it. We're looking at dividing leadership into like three roles. For example, like a lead slash OHT role, a programming slash IT role, and then a an HR role type of thing, like and divide and then maybe stipend out the total payment accordingly. But again, I think the thing is just every group should really sit down and figure out what works for them and and reward leadership.
Yeah, definitely. So to move on to another very talked about area from the FO Plus model, as many of you will recall from our previous webinar, a new patient attachment bonus is also being introduced under the FO Plus model. The bonus payment amount will vary based on three key factors: the age of the patient, your rurality index, your practice's rurality index for Ontario or RIO score, and whether you are classified as a new graduate or an established physician. There will be two separate fee codes, one for establishing physicians and one for new graduates. The specific codes have not yet been released. For each code, the ministry will automatically adjust the payment amount based on your practice's address, which determines the applicable RIO score, as well as the patient's age at the time of enrollment. Established physicians will receive somewhere between $100 and $180 per unattached rostered patient new to your FO, depending on the patient's age and the RIO score. New graduates will receive between $150 and $270 per unattached rostered patient new to your FO. So a new graduate includes physicians who join a patient enrollment model within 3 years of completing a family medicine residency, or a physician who joins a PEM within 3 years of completing family medicine postgraduate training as an IMG and obtaining an independent practice license. For physicians coming through Practice Ready Ontario, the 3 year eligibility window begins from the date a CPSO number is issued. Once you join the PEM, your new graduate status begins at the time and remains in effect for 12 months. Now let's discuss patient eligibility. For a patient to be eligible for the patient attachment bonus, they must have been enrolled with you on or after July 1st, 2025, using the group specific enrollment code, the Q200 or one of the other rostering codes, and the patient must sign the new patient declaration enrollment and consent form. So to clarify what qualifies as a new patient for the purposes of the patient attachment bonus. First, the patient must be new to your group. This means they have never been enrolled with any physician within your FHO group at any time in the past. A new patient is generally someone who does not currently have a family physician. So this includes individuals who have moved to a new community, lost their physician due to retirement, illness, death, or a change in practice model, or have not previously had or felt they needed a family physician. It's also equally important to understand what does not qualify here. The patient attachment bonus does not apply when taking over a retiring physician's entire roster through a batch roster transfer. In that scenario, you cannot bill the attachment bonus for each patient on that transferred roster. The following situations are also not eligible: newborns whose mother already have a family physician, patients who already have a family physician in their community and choose to switch to you, including those from a fee-for-service physician, patients who were previously rostered within your group, moved away, and later returned. Understanding eligibility criteria is critical for your practice, as these distinctions directly affect whether the attachment bonus can be billed appropriately. So let's also address timing and implementation. The new patient attachment bonus codes are not yet available for billing. So the ministry and OMA are actively working through the implementation details, and additional guidance will be shared once finalized. In the meantime, you should continue billing the appropriate enrollment code, like the Q200, for all new patient enrollments. This ensures the ministry can identify which patients will qualify for the attachment bonus once the codes become active. For patients being enrolled, you'll need to ensure that both the new patient declaration and the enrollment and consent forms are signed and dated on the day of enrollment. If your patients meet eligibility criteria and you satisfy all billing requirements, the bonus codes can be billed retroactively to July 1st, 2025, once the new codes are released. We recognize that managing rosters can take a significant amount of admin time, and many physicians or their staff may not have capacity to handle it consistently. Doctor Care does offer our patient care service, which helps by identifying eligible patients and submitting the appropriate rostering forms on your behalf. If this is something your practice could benefit from, feel free to connect with our team to learn more. In addition to the standard attachment bonus, there are additional attachment incentives available for Healthcare Connect upgrade, mothers and newborns, as well as multiple births. At this time, these new bonus codes are not yet available for billing, with the exception of the existing Healthcare Connect complex code, the Q053. It's important to know that each patient is only eligible for one attachment bonus. No need to worry about trying to remember all of this. I know it's a lot. We'll be creating a detailed guide on all important rostering information, including the new patient attachment bonus and codes to use as a reference in your practice. So to support you with proper roster calibration, we're working on introducing a new section in our reporting tool that would not only keep track of how many patients you roster on a month-to-month basis, but also track the use of all the available patient attachment codes, giving an overview of the total dollar amount claimed month over month. To reiterate again, our reporting shown here is just a mock-up for illustration purposes and is subject to change based on the ministry's final reporting. We will be able to finalize our reports once the codes have officially been released. In addition, we are upgrading our roster management section to give you a better overview of total rostered and derostered patients, capitation trends month to month, and include the patients you are actively seeing but aren't rostered. So you can determine if these patients should indeed be rostered, ensuring you're optimizing for your capitation. Now, let's continue to look at one of the more talked about features of the Full Plus model, the continuity of care measure. So under the FHO Plus model, the continuity of care measure is an accountability framework designed to support longitudinal patient-centered care. It looks at where rostered patients receive their in-basket primary care services and encourages care to remain within the physician's practice and their FHO. To meet the requirement, physicians must maintain a minimum continuity care rate of 75%, reinforcing care within their practice while allowing flexibility in how care is delivered. The continuity of care measure is calculated quarterly as a percentage for each individual FHO physician, based on services provided to their rostered patients, both regular and long-term care enrolled patients. So here's how the calculation works. Your numerator includes the number of in-basket services, both virtual and in person, provided by you, the rostering physician, physicians in your FHO, which includes locums and income stabilization physicians registered to your group, and acceptable other providers. Primary care visits that use fee codes within the LTC basket, which are provided by the above providers to your patients rostered as the Q202, will also be included in the numerator number. Your denominator includes the total number of in-basket services by any family physician specialty. So it's all that's in the numerator plus any other in-basket services. So it includes walk-in visits, visits to non-designated family physicians. Dr. Stewart, anything you want to add on this one?
Yeah, a few things on this, and this is another reason why I suggest people hear me suggesting breaking multi-issue visits down into smaller visits, because by doing so, if you take a say a 5-issue visit that a lot of family doctors would be doing and divide that into 2, 3, 4, 5 visits, you're therefore adding that number, that 5, both to the numerator and the denominator, and keeping. Now, that this is especially important for those practices in areas where, say GTA, where there is still probably going to be a lot of outside use, so to speak. And for those riding close to that continuity of care metric, it helps save that potential loss of income. Um, on that issue, I think I just like to take say 3 points on this one and dive into. So the reason for, in summary, the reason for short issue visits instead of like multi-issue visits under the original flow that we're currently doing are like 3 things. One is that we've talked about the more revenue from the shadow billing. If you break those 5 visits into 5 individual visits, you're still getting the $13 per shadow billing every single time. So that's 5 times the revenue there. The second point is that there's the extra time it takes to do these visits. Unfortunately, for better or worse, helps grow that direct pie of time, which we've talked about, and how important that is to therefore grow the indirect pie. And then the third is as we speak about here, is the continuity of care metric. So there's all these reasons incentivizing, unfortunately, for better or worse, short, quick, single, double issue visits type of thing.
Right. Yeah, a lot of good cascading benefits there. Thanks for highlighting that. So we're also hearing a lot of questions of what is not included in this measurement. So out of basket services like prenatal care, diabetes management, STI management are not included in the continuity of care calculation, as capitation payments apply to only the in-basket services. Non-billable clinical tasks, so secure patient emails, and care provided by non-physician providers, including nurse practitioners, are also excluded. While these services don't count towards the measure, having nurse practitioners and allied health professionals in your practice can still improve access for your rostered patients and help reduce, outside use that may impact your continuity of care score. So the continuity of care threshold has been set at 75%, meaning that at least 75% of in-basket primary care visits for your rostered patients should be provided by you or other acceptable providers each quarters. Most FHO physicians are already meeting this benchmark, with many others close to doing so. Everything you're already doing to keep patient care inside of your group is something you'll want to continue doing moving forward. If the threshold is met, there is no financial impact. But if the threshold is not met, a 15% reduction to capitation will apply if a physician remains below the threshold for two related measurement quarters, which provides you time to adjust and improve continuity. So a related measurement quarter is considered a pair of quarters, which are actually 3 quarters apart. We'll go through an example here, which will help illustrate it. Now, if your continuity of care falls below the 75% threshold for a single quarter, you'll receive a notice from the ministry. But because you have up to 3 months from the date of service to submit billings, a notification for Q1, for example, will actually only come in early Q3. So there's no financial impact for a single quarter below the threshold. This notification is meant to give you time to review your data and make adjustments before the next measurement period. So to look at an example where your continuity of care falls below and how it impacts you. So using Dr. Johnson here as an example, in Q1, their continuity of care rate was 78%, which is below the threshold. But because it's below the threshold in a single quarter, no reduction applies. As you can see, we got the rate by dividing the in-basket visits by the physician or an acceptable physician by the total number of in-basket services. In Q3, Dr. Johnson receives a notification from the ministry that they are below the threshold and will need to bring it up. No reduction will happen this quarter, but they will need to improve their continuity of care rate. In Q4, so the next measurement period, the doctor is below the threshold again at 70.9%. And this is after receiving the notification in Q3 that they are below the threshold. Therefore, in Q6, so the next time they'll get a notification, Dr. Johnson will receive a 15% deduction from their Q6 payment that relates to their Q1 capitation payment. So in short, your first instance of being below 75% will not cause any deduction. But if you are continuously low after that first instance, where it continues after the notification from the ministry, that is when a physician will see penalties. So a good example here is a physician with a roster of 1,500 patients could see around $11,000 deduction from their Q1 capitation payment if they fall below the threshold in two related measurement quarters, right? So Q3 and Q4 in this example. Again, the most FHO physicians are already meeting this benchmark, with many other close to doing so. This is just to explain how the continuity of care reduction will happen. So a common question we hear from doctors is how the new continuity of care measure differs from the previous access bonus negation structure. Negation worked as a dollar for dollar deduction to your access bonus whenever a roster patient received in-basket care outside of your FHO. Each outside visit directly reduced your bonus by the full value of the billed service. The new continuity of care approach works differently. A discount applies to capitation only if your continuity rate falls below 75% for two related quarters, as we saw in the previous example, replacing immediate penalties with a threshold-based model that allows time to adjust. So the effective date of this measurement will start on April 1st, 2026, and will apply to individual FHO physicians only, and it is calculated on a group level. Physicians will also receive a new monthly report. More details on this report will come, including whether a baseline continuity of care measure will be provided, and the date when physicians will start receiving these reports are still to be determined and will be available during implementation. Physicians will continue to receive outside use reports from the ministry, but that's not for negation, but to give you the data to know which of your patients may be triggering outside use and affecting your continuity of care ratio. It's also worth noting that the negation and the access bonus will remain for family health networks and blended salary models. The continuity of care measure does not apply to those models. Our team at Doctor Care is closely monitoring the upcoming changes related to the continuity of care. So once this new reporting requirement from the ministry are clearly defined, we will update our practice care reports to provide you with enhanced tracking and actionable recommendations to help you calibrate your roster and maintain the 75% threshold under the FO plus. So even though I just want to quickly touch on out of basket billing. So even though it won't be taken into consideration for this measure, for the continuity of care measure, it is still important that you continue to bill out-of-basket services, not just for your roster patients, but also your non-roster patients as well, to continue to receive the full fee amount for services like diabetes management, prenatal care, and smoking cessation. This not only enhances quality patient care and continuity in your practice, but also helps with overall revenue. So now that we've covered most aspects of the FO Plus model, I want to quickly talk about ways that you can optimize and monitor work under the FO Plus. So first, your indirect care percentage. You'll want to monitor the proportion of indirect care and clinical administration relative to the total billable hours to ensure you remain within the 25% threshold. Waiting until the end of a day, a 28-day cycle can create unnecessary complexity. So really referencing what Dr. Stewart was saying before here. Second, total billable hours versus your maximum allowable hours. This includes both the 14-hour daily limit and the 240-hour rolling 28-day cap. Understanding how closely you are to this can help prevent unbillable work and support better planning across the month. It's also important to maintain clear documentation of hours. Ensuring documentation is complete and consistent will help support claims and avoid unnecessary billing issues. Third, fee-for-service revenue. As hospital services shift to full fee-for-service rates, tracking this revenue separately helps you understand the true financial impact of hospital-based care under the FO Plus. Fourth, shadow billing and after-hours accuracy. With shadow billing increasing to 30% and the Q012 rising to 50%, monthly reviews are needed to make sure that eligible in-basket services are and after-hour premiums are consistently captured. Fifth, attachment incentive growth. Monitoring new rostered patients, HCC attachments, and mother newborn incentives will help you quantify one-time bonus revenue and ensure non-eligible codes are not missed. Sorry, no eligible codes are missed. And finally, your continuity of care percentage. Because continuity will directly influence compensation, you should regularly review where your rostered patients are receiving care and whether you're tracking towards the 75% threshold. So in short, and we'll get, I'm excited Dr. Stewart will explain more of this, but the FO Plus requires a shift from reactive billing to structured performance tracking. Practices that monitor these metrics monthly will be better positioned to protect revenue and maintain compliance. So I'm really excited that we have Dr. Stewart here today, and I'm going to have the opportunity to ask him a couple questions and get his frontline perspective on how to handle it. Before I jump in, Jillian, I just want to let you know you've come off camera. I think maybe by mistake. Sorry about that. So yeah, Dr. Stewart, thanks again for being here. We love having you. So I was curious, from your perspective as a practicing family physician, what has stood out to you most about the upcoming FO Plus changes, both opportunities and potential challenges?
So what's really stood out is that how the model changes incentives. Definitely more incentive for time and volume of visits, and especially direct care and direct care specifically by the doctor. Whereas the original FO rewarded efficiency and delegation. That's not really the case so much with FO Plus. Another thing that stands out is there's far less flat rate stability. I kind of did some quick calculations and figured that the average FO doctor working 8 hours a day in a clinic and seeing maybe 20 plus patients is gonna if you miss a day for whatever reason of work, you're gonna notice about $1,000 difference per day on the next month's RA. Now, then none of this is news to any fee-for-service doctor out there, right? So, um, in terms of opportunities, the Full Plus definitely brings some opportunities for those who wish to increase and maximize the revenue, as we've kind of I spoke about throughout. Quick, short, I don't want to call them single issue visits, but let's say non-multi-issue visits will generate more revenue. Phone calls instead of messages and so forth. Secondly, a doctor can actually keep a roster small. I mean, by definition, a 1,000 patient roster has less paperwork and less overall demand and burden than a 1,300 patient roster. And you can make up the difference in revenue now through churning out volume and visits, for better or worse. And third, there's an opportunity with respect to uninsured services, which is a topic near and dear to my heart. For those of you who aren't already charging for prescription renewals, figuring it's just a little 2 minutes here, a little 2 minutes there, the opportunity cost is going to become more obvious in that every prescription renewal that you forego gives up a visit, which would amount to about $26 in terms of hourly rate plus shadow billing, plus the detriment to the count-needed care metric, and plus the detriment to the direct care and thus indirect care pie. Similarly, there's opportunities for online medical advice. Receiving medical advice via email or secure portals has never been covered. A lot of us forwent that for the sake of efficiency. But now there's more of an opportunity cost to be sending off emails because again, your indirect care time is going to get maxed out. And then to wrap all this stuff up, there's an opportunity for successful block fee programs. And if you're at all interested in any of this, I strongly urge you to consider contact Patient Serve who's also a Wellstar company now, because they will make your life improve your life as much as they've improved mine. The challenges with the Full Plus, of course, it discourages efficiency and delegation. It unfortunately discourages patient self-management, keep out of, self-manage at home, read my website. That's no longer the case under Full Plus. Large rosters are disincentivized, and oddly, at a time when government and PCAD and that are trying to solve the unattached patient crisis. I don't know. And the Full Plus doesn't properly reward innovation and scalability. For example, like I use Ocean and I'll pull these mass emails or mass email lists of people who are due for preventative care or tests, and I can send those out in a few minutes. Now, some might argue that that's covered at under the $80 admin time. However, we've already spoke about most people are going to already have exhausted that pie of time, so it's going to be paid at zero for the most part. Plus, the value that provides, I'm just going to suggest, is worth more than $80 per hour. So to summarize all of this, what is to say is that whenever incentives change, behaviors will change, and we're all about to see how this plays out in real time over the next year or two.
Yeah, yeah, really interesting. So I was curious, do you anticipate any operational adjustments practices may need to make once the Faux Plus is in place? I'm sure you do because after the last
Yeah.
answer.
So So absolutely, doctors should consider workflow redesign. On one hand, there's many who won't want to change a thing and they'll still enjoy an 10 to 18% raise. The math kind of shows that the small to average practices will do quite fine under Full Plus without changing a thing. However, those who see maybe a reduction in their next RA might start wondering. Larger practices will definitely want to adjust. The loss of the CCM fee and the access bonus is just as not as favorable in making it up through the hourly rate. It doesn't work out that way. So as I say, I have a large practice. I'm gonna have to shift to much more single issue or shorter visits. Those doing other things outside of a FO, like ER or surgical assist or hospitalist, who aren't in the clinic seeing patients Monday to Friday, are maybe wanting to adjust or are going to see the reductions in the RAs. But here's one of my biggest points in this whole section is that faux to faux plus, the original faux to faux plus has turned a lot of things on its head. So everything that I used to teach about efficiency has kind of been thrown out the window. So for example, I used to teach about how under the original faux, in-person visits were the most precious. And now everything should be seen. Now it's like the opposite. Come in and see me in person. I used to delegate to staff or just to tech, no more mass emails. Used to delegate to staff, and now it's no more reeling a message to the staff. That becomes a phone call with me. I used to keep my online booking kind of filtered, again, trying to save those in-person visits. Now it's upfront on the front of my website. Come in, come all. My website for self-management, I used to direct people there pre-visit to try to save visits. Now it's like, nope, come see me. Prescription renewals, I used to teach about setting a patient free for a year if you can, empower them with renewals. Now I might want to start limiting, instead of 3 refills, I got 2 refills, for to increase the visit frequency a little bit for better or worse. Um, Emailing patients results, used to do that very quickly. Now that at least becomes a phone call reassessment visit. And interesting, I'm already seeing this as I've been ramping up for FHO Plus. Because I was so judicious in my use of saying or in-person visits, my schedule always had open access. Like I had open spots every day. And now under FHO Plus, I'm going to want to see my day filled at the start to the end, not only to build that direct care, but maximize my direct care, but to also make sure that I've got enough volume of visits. So for better or worse, this is going to or for worse, that's going to translate into some longer wait times than my patients are used to.
Mm.
And I already spoke about in terms of the last operational workflow. I already spoke about it, but there are changes to uninsured fees workflows with respect to say, especially prescription renewals, but also the online email care. So many practices who have optimized themselves for the old FHO under FHO Plus, those same workflows are suddenly going to become suboptimal.
Yeah, big changes there. Really big changes. Interesting. So what aspects of the Faux Plus do you think could positively influence how practices operate or organize their work?
So we've already spoken about the revenue potential, but I want to, this little pearl. This is bringing patients back into the office for more of these in-person visits has had positive effects that I've already seen. And I'm going to maybe sound a little old school here, but since changing to more in-person visits, I find that there are things that I think I might have missed prior, like a little comment by a patient, a little observation, a little nuance that I might have missed without seeing the patient in person. And then, of course, patient rapport is improving, and dare I say that's translating into a little bit more joy in being a family doctor again. So this is all good things. The other thing is that, and related to this, I made a video on this months ago, is that I predict that because the old FHO, all of us doctors were a lot of us were trying to say keep patients healthy and out of the office and try to self-manage, try to not come in, right? Whereas some patients were wanting in to see us. Why can't I just come see you? That's going the new full plus model kind of better aligns the patient and doctor expectations and goals here. So we'll probably see some less friction and less resentment in that area too.
Yeah, well, it's funny how things come cyclically like that.
Yeah.
So from your perspective, what are some of the key metrics physicians should be paying attention to?
So this is an area I love as the efficiency guy, but and I've already been building spreadsheets and mathematical models over the last few months to look at all this stuff myself. But I think you've gone through a lot of this stuff like hours worked, uh, visit volume, number of visits, and related to that, a number that often people don't think about, but is very important, I think, is the average number of visits per patient per year. And under the old flow, we wanted to keep that number small, do as much as you can in one visit. Now we want to keep that number large, as I've spoken about. The other metrics that have to do with the continuity of care and roster size, obviously, and of course, revenue. And not just revenue, but I always like to look at revenue per hour because that's uh, that's probably more important. Um, in summary, though, for the first time, family doctors may need to start running their practice a little bit more like a dashboard. And I'm not saying that's a good thing. That's probably not what most people want, but that's where supports like you've shown how doctor care might maybe playing an important role.
Interesting. Interesting. Yeah, keeping an eye on all those key metrics on a regular basis changes the way you practice. So given your interest, as you've mentioned, in practice efficiency, how important do you think it will be for physicians to monitor key metrics? Funny, you just you dove into that a little bit, but like covering some of these key metrics and how can digital tools maybe support that under the Faux Plus?
Is it, and I think there's going to be a range of preferences here. Like as I said earlier, many doctors don't want to necessarily change. Many aren't financially driven, at least as a priority. They won't feel the need to change. And again, unless of course all of a sudden next month's RA is $10,000 less than they were expecting. On the other end of the spectrum, you've got people like me who I want to optimize whatever model I'm in. You give me the rules to your game, and I want to figure out how to optimize it. I want to figure out how to squeeze every drop of juice from that orange. So for those of us like me, digital tools and things like this become critical. Um, Digital tools that look at visit patterns and time allocation or patient panel dynamics and of course continuity care metrics type of stuff. And as an example, I can even envision like opportunities where tools might show a doctor examples of how adding a few phone calls or a visit or two at the end of the day, maybe an extra half hour, might change their revenue over the course of a week, a month, and a year type of thing. So if doctors aren't measuring how their practice operates, you're not really realizing how the new incentives are maybe affecting you for better or worse. And you might not realize how things could be different with respect to revenue and time. And the easy example there is that we've spoken about is that many doctors will probably exceed the indirect slash admin cap without even realizing it.
Yeah. I do want to flag, we probably have about 5 more minutes of content. I know we're about at the hour mark. For those who can stay, by all means, of course, you need to drop. We will be sending the recording out after 2 more minutes. Okay.
Two more questions, right?
Two more questions. Two more questions come from Dr. Stewart. Yeah. So, what kinds of conversations are you hearing among physicians about the Faux Plus right now? And are there common questions, concerns that seem to be coming up most?
Yeah. So some are looking forward to Fo Plus. As I say, small to average practices are looking forward to the hourly rate, being rewarded for their time, the shadow billing, the reward for complexity and time. The modeling suggests again that the average doctor will do quite well. Larger rosters and including rural practices like mine, who are already getting most of their access bonus, that math isn't as favorable. There's a lot of curiosity, I think, from people too about how should I adjust my workflow? Are single issue visits really the way to go? And people are looking for candid and practical answers. One important point is there's been a lot of confusion about the hourly rate in uninsured services. And to be very clear, the hourly rate, as you said in an earlier slide, does not include uninsured services. The definition was very carefully written that the hourly rate for the indirect care time includes time related pre or post an insured visit. So, for example, if a patient writes an email to you and as an independent encounter and says, "I need a prescription renewal," or faxes a prescription renewal without a visit, that's its own thing, not covered under the hourly rate. Physicians don't want to risk or lose that revenue stream. Um, I think, and finally, there's a lot of confusion and angst and apprehension about like this is a very complex model now, and and everyone's a little unclear. And it's going to be interesting in May and June to see when people get their first RAs. Are some riding close to the continuity of care threshold? Some are going to be very happy, and some might be a little bit panicky and scrambling. But again, that's where supports like Doctor Care can really come in.
And last question, and your wealth of knowledge. So, curious what you think is as the Faux Plus begins to roll out, what advice would you give to family physicians working under the new model?
So I think I'd start by just taking a pause and really thinking about what are your priorities? Is it money? Is it having that extra revenue to take your family on a luxury vacation at the end of the year? Or is it time? Is it getting home by 3 p.m. every day? Is it efficiency? Is it pace of work? Like what is your priority, maybe one and two, and let those be the kind of guiding stars on how you may or may not want to adjust. And then don't necessarily panic in May and June when these first RAs start rolling in. Just be open and ready to evolve if you need to. And if you are concerned, I think be willing to redesign your practice and seek help when you need it. I mean, the biggest mistake would be that assuming we can all practice exactly the same way under a completely different incentive structure.
Yeah, yeah. Amazing points. And again, like I said, your wealth of knowledge. So I just want to thank you so much, Dr. Stewart, for your time and your expertise that you've shared today, and very, very appreciative that you were able to join us. I do want to quickly say we've got a couple more slides. If you do have any questions we didn't cover, please submit them through the Q&A feature. If we can get to them, we will. If not, we'll follow up after the webinar as well. So just quickly, before we wrap up, the model introduces a lot of moving parts. Managing all of this manually will require a significant level of administrative oversight. And Dr. Cares here is working to create structured reporting and digital tools that will help provide clear visibility into your billing activity. So our monthly practice care reports will be designed to specifically provide consistent, actionable insights into the metrics that matter most. This is something our team has supported physicians with for countless years and will continue to do so. So what we're looking to monitor on our end is, indirect care percentages and category allocation, which is going to be new to our reporting. Total billable hours versus rolling caps, which will also be new. Average monthly revenue, as Dr. Stewart alluded to, will be really important to keep an eye on, especially the first few months. Your out of basket revenue performance and your attachment billings as well, all things we've spoken about today. So our goal is, instead of manually reconciling spreadsheets or relying on retrospective reviews, you'll have real-time visibility into how your practice is performing under the new model. Because the reality is that the FO Plus increases both opportunity, as we've spoken about, but also administrative complexity. Having the right systems in place will play a key role in ensuring those changes translate into stronger performance for your practice. So if you'd like to understand how these changes can affect your specific practice, we do invite you to book a complimentary FO Plus analysis with our team. We can help you understand the new FO Plus model, assess your projected income, and highlight opportunities to optimize performance under the new framework. So there is a QR code on the screen, and I'll stay on the screen for a few more seconds. So feel free to take your phone out, scan it, and you can book a meeting directly with our team. Alternatively, you can contact us at info@drcare.ca to request your analysis. And I'll stay here for 10 more seconds just so anyone can scan it. And if you don't have your phone with you, feel free to email us after. And this is just wrapping up our webinar today. I just want to again thank Dr. Stewart for taking the time joining us, and for everyone here that joined us today. On behalf of Doctor Care, we appreciate your participation and we hope you found it informative and valuable. If you have any questions or feedback, really feel free to contact us, or you'll see our contact details right here on the page. I hope everyone has a wonderful day. Thank you.